So this is my ASD talk. I'm Behny. I've given this talk before, and this is the same one, with the exception of a case that I'll be showing you in a little bit. Just jump in if you have any questions. And I've realized from previous episodes, it's very easy to misspeak when you're describing the ASDs and the anatomy and everything. So if I've said something wrong, please interject and correct me. Okay, so when to suspect ASD. So I think probably the one that I use that has tweaked my radar to go looking for an ASD is probably right heart enlargement, actually. Clinical signs and sequelae, yes, of course, like if you're worried about somebody who's landed in your ICU, they're on a ventilator with a pneumonia, and you think maybe their right side pressures have gone up and previously irrelevant or undiagnosed ASD or PFO might be causing a right to left shunt. ASDs don't usually cause a right to left shunt under normal conditions, but if you're worried about that, then you go looking for an ASD to explain their hypoxia, for example, as well. But in my experience, like those are actually usually negative. And what I have found is actually right heart enlargement. So these days, when I see a large right ventricle and a right atrium, and it's not easily explained with something else. So other things that might cause dilation that are quite common are things like significant TR, because you're volume loading the right ventricle and the right atrium, and any associated pulmonary disease. So if I'd quickly look for that, and then I'd also look for an ASD as well. So the process, I think this was a little summary in a paper I found, I think it's quite good. So exactly the first thing would be a volume overloaded, or the appearance of a volume overloaded right heart. Then probably the best view to see most ASDs would be the subcostal view, and I'll go into why that is a bit later. And then so you determine where it is, and that'll tell you what kind of ASD it is. I'll go into that a bit later. And then number 4, determine the direction of the shunt. And again, that kind of will help you differentiate an ASD from a PFO. And then you, if you can get a good alignment, put a Doppler through it, because a small hole is going to cause a higher velocity, and a big hole is going to cause lower velocity, and then that'll give you some information as well, and the shape of the curve, and then associated defects. And the last thing, it says determine suitability for device closure. In my experience, I just refer them to cardiology. What would be great is if you could get 3D and then do measurements of the rim to all the relevant structures, because that determines whether it can be closed with a device or not. But in my experience, it's too hard, so just give it to cardiology. And actually, the last time I did that, they asked for a QPQS, and I was really surprised, because I don't think that's a good idea at all, and I'll explain that a little bit more later. So just going a little bit through the anatomy, and it's actually quite important to have some understanding of the embryology of the heart to understand how the ASDs occur. So the best way I can explain it is, so around about 4 weeks or so, you get a very primitive heart. So you kind of get the atria without septation, and the ventricles without any septations, and so a little bit before this, and the atria are actually formed from the same embryological structures as the veins. So the pulmonary veins, the IVC, the SVC, and the atria all sort of confluent, really. And the venous anatomy when it's forming is really just quite a mess. Like there's a lot of pipes out the back of the heart. And so when you think about that, you can kind of see how it would be easy for some wires to get crossed there and for some septations to not form properly. So this is what I'm talking about. You have all this sort of this mess of veins at the back. And the reason why that's relevant is because some of your atrial septal defects are actually not true atrial septal defects. Only your Primum and Secundum Asds are actually true defects in the septum between the atria. Whereas your other ASDs, which is your sinus venosus and coronary sinus ASDs, they are actually communications between a vein and the atrial wall. So not between that actual partition between the atria, technically. So the key to understanding a Secundum Asd and a Primum Asd are the septations that occur in the heart when it's forming in the atria. So the first thing that happens in your primitive heart here on the left, in image A, you have the two atria, there's no septations between them, but this ostium primum, ostium primum forms from the septum primum. So this septa that comes down, it's called the septum primum. And there has to be a hole there because in the fetal circulation, if you recall, essentially you're kind of bypassing the pulmonary circulation. So you've got to go from the right heart straight over to the aorta. And the way that happens is it goes through eventually what's the foramen ovale down in D. But if before that forms, you need a you need a persistent communication between the atria in order to allow the fetal circulation. So that persistent opening in the first instance is called the ostium primum. So this is a lateral view, and that's right above what becomes the atrioventricular valves in the fully formed heart. So it's just above the atrioventricular valve in the septum of the atria, between the atria. Then what happens is you get down in image B, you start to get perforations. So it's normal to start to get perforations in the septum primum. Why do you get perforations in septum primum? Because this ostium primum is going to close. So this grows down and closes. And then that persistent communication that you need to allow the fetal circulation actually occurs through these perforations, which becomes a hole. So you can see that here in image C. And a second septum grows up, or grows, well, like on this diagram, think about it as growing kind of towards you. And that is the septum secundum. So the septum secundum grows immediately to the left of the septum primum, if I've got that right. No, I think it's the right. And so these perforations become a hole, and that is actually your foramen ovale. So these holes line up, that becomes your foramen ovale. Now in the next picture, your foramen ovale closes over when you get the pressure changes, and there's a flap that comes over to close that foramen ovale. And the foramen ovale will only close properly if the flap from the septum secundum is like developed enough, I guess, is how you could think about it. So if it doesn't close the whole hole, or if it closes but doesn't fuse, then you get a patent foramen ovale. Does that all make sense so far? So that's how you get a patent foramen ovale. If you don't have if your septum primum does not close properly, so back here in image B, if this hole above the atrioventricular valve doesn't close properly, you'll get an Primum Asd. So the Primum Asd, the primum in that refers to the septum primum. So it's a hole in the primum septum. Does that make sense so far?
Yep.
Yep. Okay, good. All right. And then a Secundum Asd occurs because the flap that is supposed to grow over to close this perforation here, that doesn't develop properly, so you get a Secundum Asd. So the Secundum Asd is referring to the how do I explain this? Yeah, it's actually still this is where it gets confusing. You have a primum septum and a secundum septum, but both a primum Asd and secundum Asd are actually defects in the primum septum. Does that make sense? So if these holes, right, are not properly closed over, you by the secundum, the hole's actually in the primum septum. Does that make sense? So they're actually defects in the same septum. And the reason why that's relevant is because a Secundum Asd and a PFO on your echo are in exactly the same location. So there are things that you can use to differentiate what they are, and they behave differently. So I actually don't think that some people put PFOs in the same category as ASDs. I don't, because you don't get the same hemodynamic effects as from a PFO as you do with an ASD. So a PFO doesn't cause right heart enlargement. ASDs do. PFO will give you a right to left shunt at points where the right atrial pressure is higher than the left atrial pressure. But an ASD, because you need a higher pressure in your right atrium to open that flap. But an ASD doesn't do that, because you usually, for most of the cardiac cycle, will have higher pressures in your left atrium, and there's no flap, there's just a defect. So in an ASD, your shunt is left to right. And that's why you get a volume overloaded right heart, because you get blood from the left atrium going to the right atrium, going to the right ventricle, pulmonary circulation, left atrium, right vent. So you get extra recirculation through the pulmonary circulation back to the right heart. So it becomes a volume overloaded right heart. Does that all make sense so far? It's actually easier when I draw it, but I can't do that here right now, so sorry about that. So the types, so the primum Asd is, you are actually you're quite unlikely to see a primum ASD. And the reason for that is the vast majority of them, so I've written 60% are Secundum Asd, but depending on what source you read, some of them are 80 to 90%, they'll say is Secundum Asd. And then the rest of it is pretty much all primum Asd. And then the other two kinds of ASDs that you may have heard of are sinus venosus and coronary sinus. And they're very rare, very rare. So what you're most likely to see is the Secundum Asd. And then the other reason why the primum Asd is you're less likely to see that or less likely to, find a de novo diagnosis of that is because it's actually part of a spectrum of congenital heart diseases called atrioventricular canal defects, which is what AVCD stands for. And with atrioventricular canal defects, you'll have a primum Asd. You might just have that, but the whole spectrum is your atrioventricular valves could be abnormally formed, malformed, like septal leaflets, not septal leaflets, but any of the leaflets might not be formed properly. The whole valve might just be joined and you just have one valve across both ventricles, and then a VSD as well. So that's why they call it atrioventricular canal defects, is because that the canal of the heart, like the bottom of the atrial septum, the atrioventricular valves, and the top of the ventricular septum is a defect. So in the extreme of that congenital heart disease, you'll have like a uni atrioventricular valve, a primum Asd, and a VSD as well. So that's more likely to be picked up when people, children younger or congenitally, because it's congenital heart defect that should be screened for as well. So you're less likely to see that or diagnose someone with that. And the Secundum Asd, other than being very far more common, it's actually the most difficult to diagnose intrauterine when they do a congenital heart disease screening, because you're supposed to have a defect there. That's what the Foramen Ovale is really. So it's hard. You can't actually diagnose it intrauterine. And then if it's not significant enough to cause, severe right heart overload, and then all the sequelae of that, which is again very, very rare to have an ASD that bad, and that picked up and to cause that many problems that will be picked up in childhood. So that's why you're more likely to see Secundum Asd. And some of the sequelae that I'm referring to are like if your right heart gets volume overloaded to the point that it can't compensate anymore, and then then the pressures go up, and then your shunt, then you can get pulmonary hypertension, and then your shunt direction can equalize and then reverse, but that's way down the line. What you would first see is very dilated right heart, then pulmonary hypertension, and by that point, probably would have picked it up. And then the other two types are sinus venosus Asd, very difficult to pick up on a transthoracic, and the same with the coronary sinus Asd. So the sinus venosus Asd is difficult to pick up because the standard views that you use for a transthoracic, they don't actually cut through a point where you would see that. So you would have to have a high index of suspicion, then go looking for it. And then even then, it's very difficult to visualize the SVC properly on a transthoracic. So there it's kind of suggested that you do a toe if you're worried about something like that. Again, pretty unlikely. And this is a sinus venosus ASD is not, as I alluded to previously, is not a true atrial septal defect. It's actually a defect in a communication between, it's a communication between vein, the SVC or the IVC, depending on which type, and the right atrium, sorry, and the left atrium. So it's when that mess of veins, when the heart is forming, they kind of form a little bit too far to the left, and the septations didn't occur properly. So you're supposed to have a bit of atrial wall there, and then the atrial wall is missing. So then you have a communication. And then the coronary sinus ASD, you can pick this up on a transthoracic if you see a really large coronary sinus. So you should get with this ASD, because you have a lot of venous return being dumped directly into the coronary sinus, usually from an extra SVC on the left. You get the coronary sinus essentially gets overloaded. And then again, that's not a true atrial septal defect. The defect there is the bit of the atrial wall. So the coronary sinus runs around the left atrium, right? And then that bit of atrial wall is missing. And you can have like all of it missing, and that's what they call completely unroofed, or you can have little bits of it missing, and it's just little holes, and that's the perforated kind. And a way to diagnose it if you're suspicious of it on a transthoracic is do a bubble study, but on the left arm, and then those bubbles will travel into the left side of SVC, which is associated with this defect, and then straight into the left atrium. And then, as you know, when you normally do a bubble study, that unless you have a communication between the heart chambers, you shouldn't see any bubbles on the left side at all. They should all be dissipating in the lungs. So normally they would go back to the right heart, dissipate in the lungs, so you don't see anything in the left. If you see something across the atrial septum, then there's defect in the atrial septum. But in this case, if you're injecting into the left, you see nothing on the right side, and it goes directly into the left atrium, then you've got your diagnosis. Is this all making sense so far?
Yeah, I think so. It's good.
Yeah, thanks, Benny.
If there's any questions, just jump in, or if you want me to clarify something, because I haven't. Like I said, the terminology is quite, it's easy to misspeak, so let me know if I've done that. Okay, so this is just another diagram that kind of, I think, is helpful in understanding them. So again, Primum Asd doesn't have to be this big, but the point here is that it's just above the atrioventricular valves. The sinus venosus defect is kind of what I was talking about with this kind of SVC type or IVC type. It doesn't actually have to be a defect in the IVC or the SVC. It's kind of near the SVC and near the IVC. What they're really talking about is inferior or superior, sorry. So the correct terminology of that is a superior type sinus venosus defect and an inferior type sinus venosus defect. And what they're talking about is actually just communications in the veins, and that goes across to the left atrium. Communications with the veins and the atria that goes across to the left atrium. And this one is, if I got that right, yeah, frequently sinus venosus ASD is, for that reason, is frequently associated with anomalous pulmonary vein connections. So the pulmonary veins might not empty into the left atrium. The most common one is the right upper pulmonary vein, and that actually empties into the right atrium. So you've got a bit of crisscross. Yeah. And then the Secundum Asd, what this is demonstrating is you can have various kinds of morphology, for lack of a better word, of the hole itself. So it can be one big hole, one small hole, or multiple perforated holes, multiple little holes. And the reason why you can get these differences is because if we go back to the embryology, so if this formation of the fossa in the septum primum arrests at this stage, and then your ostium secundum isn't overlapping it correctly, then that's the perforated type of Secundum Asd. So you have multiple little holes instead of one big hole. So that's why there's variations in what it could look like. It depends on the stage at which things went wrong while the heart was developing. So these are the guidelines for looking at the assessment of ASDs and PFOs. So I encourage you to have a look at that. And there's some images from there that I'm just going to be talking about. So again, another sort of picture. So sinus venosus SVC type, sinus venosus IVC type. Then you have the ostium secundum, the Secundum Asd, and the ostium primum, which is Primum Asd, and then the unroofed coronary sinus. I think I have a better picture of that later. No, maybe I don't. Sorry about that. I thought I had a better picture of the coronary sinus ASD. So, yeah. So this is just demonstrating that it's above the atrioventricular valve or tricuspid valve on the right side. And so this is what I was talking about. This is sort of the last thing. You've established that there's an ASD and the shunt direction and everything, and now you're sort of determining the suitability for device closure. Why? Because pretty much the only ASD that's usually suitable for device closure, like an Amplatzer device, for example, is a Secundum Asd. And PFOs, right? But the others are not. And the reason for that is because they're too close to other structures. Like a Primum Asd is just above the atrioventricular valve. So when you put the Amplatzer, you need a rim, I think the cutoff is about 5 millimeters. So if you don't have 5 millimeters between the hole and the valve, then you're going to impinge on the valve. So that's why they can't use like the Amplatzer for a Primum Asd, but they can for a Secundum Asd. And then when you're reporting it, you would describe the hole. Is it solitary? Is it multiple? And describe how far it is from each structures. If you got 3D and you're good at it, this would be a nice place to use it. And then you describe it in terms of the rims. So the rims are labeled according to what structure they're closest to, like the IVC rim. If you'd say, the defect measures, the IVC rim 12 millimeters. SVC rim, aorta, like it's a 7 millimeters, aortic rim or something like that. You could report it like that. I mean, I don't think you have to go through every single one, but you're kind of just describing that you do or don't have enough room to put a device on there. That said, there's sort of there's newer devices that interventional cardiologists can put in for, like the sinus venosus ASDs, for example, and they're basically like a fancy kind of stent that just separates the atria from the vein. So those can still be closed by interventional cardiology, but just not with an implanted device. It's a different device. But like I said, I wouldn't be going into all of this. I think it's too hard, and by that point, you know that they definitely need specialist follow-up. So I would just refer them to cardiology and see, get them to do probably their own echo and yeah. And then again, this is sort of just describing that those Secundum Asds are very variable in their size and shape. So this is a picture from the guidelines. This is a picture from this textbook, so called Echocardiography in Pediatric Congenital Heart Disease. And it's upside down because that's how they do pediatric echoes. If you didn't know, it's awful. It's really hard to figure out. But just to orientate you, so here's the left atrium, right atrium, aorta, LV, RV. Can you see my mouse, by the way?
Yes.
Yeah, we can see that.
And he have a very large hole between the left atrium and the right atrium. This is a Secundum Asd, and I think honestly, if you do see any kind of communication, just bet your money on the Secundum. It's probably not anything else. I'd be very, very surprised if you see anything else. So this is just different views of the same defect. So this is sort of flipped. So if we're doing a toe on an adult, so this is the left atrium, the right atrium. So this is your bicaval view on a toe. And again, you can actually see this defect quite well. And this is the view that you would usually use to look for PFO, right? So this is actually where your ostium secundum would have grown over to close that flap, but it hasn't done that. There's a defect there. And then this one is just showing the Doppler, and that is a left to right shunt. Yeah, that's right. Yeah, left to right shunt. As it should be in an ASD. So, and this is PFO. So another thing that might clue you into a PFO being present is a very mobile septum, and particularly this thin membranous part of the septum that normally closes over the fossa ovalis. If that's really mobile, like here in this bottom picture, you can see how mobile it is, then you would look very hard for a PFO. That's also called aneurysmal. And there's like cutoff measurement cutoffs in order to call it aneurysmal. I think if the base is more than 1 centimeter and then it comes out at least 1.5 centimeters, I think, then that's called an aneurysmal or more. So those measurements and above. And this is why on a toe, when you do do a toe and you're looking for a PFO, I've seen some people just use like the short axis at the atrioventricular valve level and that wraparound view, and because you can see the intraatrial septum there, but you can't see this thin part of the intraatrial septum, and then they'll kind of put Doppler over that and be like, okay, there's no PFO, there's no ASD, and I don't think that's good enough. You really need to see, and I think I've spoken to cardiologists about this before, and at least the ones I've spoken to agree, you really need to see this flap. So you need to see this flap, put some color over it, and then do a bubble study to really rule in or out a PFO. So this is a little bit different. So we don't normally do this. This is an intracardiac ultrasound, which goes into the right atrium. And again, it's just showing Secundum Asd. Yep. Does that all make sense? Any issues? And then the implants a device over it. There's a left to right shunt as well, as it should be in an ASD, which is what you'd expect in an ASD. So this is an example of the Primum Asd I was talking about. So Primum Asd, you could pick, so the Secundum Asd on a transthoracic, I think the best view is the subcostal forechamber, because your atrial septum is kind of perpendicular to the ultrasound beam, so you get a nice view. But with a Primum Asd, any forechamber, so like your apical forechamber, would work as well, because unlike with the so that membranous part of the intraatrial septum, if you're in a forechamber and your ultrasound beam is parallel to the atrial septum, you can just get dropout, and that's purely just a function of the fact that the membranous septum is thin. So it might look like there's a hole there, but there isn't. And then, but with the Primum Asd, that's not the case, because the part of the atrial septum you're looking at is the muscular part, the thick part, and it's right above the valve. So you can see that in any forechamber. And what you might see, as I mentioned before, is abnormal intraventricular valves as well. This is much of the same, and I just want to show you this case. So, so this is from the guidelines as well. So this is showing, Ben, maybe do you want to have a go? Tell us what you see.
Yeah, sure. So subcostal forechamber, I'm guessing it's some sort of exercise stress test. The most striking finding is presence of a left to right shunt. In the post-exercise film series, as shown by the color Doppler, it looks to be multi-jet, and there's no color on the pre-exercise, is there? There's just, oh, sorry, it's all pre. Sorry, I thought it said post.
Well, it's just looping.
It's all pre, my mistake.
Yeah,
yeah, so we're seeing a left to right shunt.
Color, yeah.
With color, the interatrial septum does look aneurysmal in this view, and there looks to be right atrial, at the very least, enlargement. So it looks bigger than the left. I think that's just some reverberation artifact. That's that structure that appears to be moving across the left. Yeah.
Yeah, it might be device in there, or like a like a line or something. I'm not sure. It might not be artifact as well. It's hard to tell.
So this will be, there's an atrial septal defect with a left to right shunt. Yeah.
And I think there's multiple defects in the CT. So this, when you see this, I mean, so what kind of ASD do you think this is?
Secundum.
Yeah, like it has to be a secundum, partly because it's just so perforated as well. Like, to my knowledge, you don't get that with other ASDs, and where it's located, it's like smack bam in the middle, and there's a left to right shunt, so it's not a PFO, it's an ASD, and it's not like a defect in that flap. It's directly through it. That makes sense. Okay, I think that's it. And I'm just going to share this screen so I can go through this case. So I might ask Ravi what you can see on this one.
So this is subcostal four-chamber view with a color Doppler window on the interatrial septum. So I can see biatrial enlargement, and I don't see any actually. What's the scale? 59. So maybe if we lower the scale to look for lower flow across the interatrial septum.
That's a really good point, Ravi. So your flow, your velocity should be around 40.
Is
40 or lower. Yeah.
is this like a Bodhi?
No.
There's like a little flash of color between the right atrium and the left ventricle.
No.
No?
There is, okay, there is, I'm going to show you another one. Okay, so what do you think of this? You see anything there?
So even on this, I'm unable to see any flow across the interatrial septum.
Okay, and how about this one? I'm going to slow it down a bit.
Maybe in a couple of frames, we can see a jet right in the center.
Yeah, it's yeah. So it's very quick on this. When you're actually scanning, you will see it better. But these are stills of the jet. So this is a still, you can see this jet going this way, and here's another one. And if I can convince you that find my frame. On the 2D, you can actually see defects in the septum. So there's a defect there.
Yeah.
And then there's a defect there. So there's at least 2 defects that I could see on just the 2D without the color. And then I was trying to catch the jet across. And then the thing that clued me in to even look at this is, as you've correctly mentioned, is this right heart is quite large. It's definitely dilated. The right atrium's dilated. Just see if I get a better view. But you can see that, right? The reason why it's not a Gabodi defect is because it's much more likely, just if you're just going to play the odds statistically, to find a Secundum Asd than a Gabodi defect or any other kind of ASD. They're so much more common that you're more likely to run into this just just doing routine scanning. So can you see this color jet coming across this defect here? Just slowed it down. Can you see that?
Yeah.
Yeah, so that's what you're looking for. You'll see it. You'll know when you see it. I'm confident. I trust you. I believe in you. You can do it. You'll know when you see it. But that was a very good pick for the velocities. Your velocity should be lower, and I've lowered it on this one.
Just one question, Behny. On the 2D, this defect in the septum.
Yeah.
Is there any other view we need to do to just confirm? Because just in one view, it might be difficult to comment, isn't it?
I mean, technically, I guess the overarching rule is don't diagnose anything off one view. That said, that the best view to diagnose an ASD, particularly Secundum Asd, is on this subcostal 4-chamber view. It's where you get the best alignment of the atrial septum to the ultrasound beam, but also you see the most of the atrial septum on a transthoracic. So you could do a short axis. You would see, the septum there as well. But so that's another view you could look at. So this is subcostal short axis again. So the septum lines up okay, but you see less of the septum. So I guess you're just less likely to pick it up, and you kind of fan up and down. So you kind of, you may miss it. Like you're going more in a more of an inferior superior kind of direction rather than anterior posterior direction with your ultrasound probe, like you are on the 4-chamber. Makes sense, yeah. So and then there's little we're at time, but so I'll finish there. There's other little caveats as well. Like I think, practically you probably won't affect you, but for exams, I mean, if you want to be really impressive, you could say things like, like the atrial septal defect kind of offloads the left atrium. So if you've got mitral stenosis, you might not actually pick it up, because you don't have the same amount of flow going through. The pressure is just not there. The pressure is getting offloaded over to the right side. This sort of little things like that you could talk about as well, but I think, practically not that useful. And just a final note on QPQS. There is like a QPQS cutoff to say this is hemodynamically significant and needs to be corrected, and I think it's 1.5. So you get like 1.5 times the circulation going through your pulmonary circulation as opposed to your systemic circulation. But this, I think the echo measurements of that are so fraught with difficulties, particularly if you don't do it commonly, like we don't do it commonly, that it's just fraught with errors and it's kind of pointless. If you're really interested in it, I think the most accurate is to get a cardiac MRI for that sort of thing. But yeah, just to let you know that exists, and but everything I've read kind of says it's got a lot of errors associated with it. Any questions?
Would you do a tour for this patient? Like, did you do a tour for this patient?
No, this patient actually, I referred to cardiology. So this one was interesting because we picked it up just during our, I do bedside basic echo, so like focused cardiac ultrasound, only 2D for our registrars and residents once a week. And we just picked it up there. So I saw that the right heart was a bit large, and I felt, whenever I see an abnormality on just scanning for learning, there's an obligation there to look for any pathology and then appropriately refer on, right? So so I saw that the right heart was large, so I put some color on it after the teaching and found this defect, and then just, because I have nothing to do with this patient, this was an ICU patient, so I just recommended that the team refer them to cardiology for an incidental finding of a hemodynamically significant ASD. What I call hemodynamically significant, because you are getting right chamber enlargement, so that technically there must be some hemodynamic effects from that ASD. So, but then the cardiologist, this patient had cancer, and they were actually kind of moving towards, limitations of care and that sort of stuff. So it made zero effect on their outcome, and the cardiologist got another echo, a formal echo that would quantify the QPQS. The shunts didn't qualify, like it was less than 1.5 ratio. And they just educated the patient and said, look, there's a theoretical risk of stroke. You're happy to accept that. This is invasive procedure. And the patient was like, yeah, whatever. And so nothing really came of it, but it was interesting. And I do think it's important to, just be responsible with our scanning. So.
Thanks very much, Behny. I've got another interesting case of an ASD if people would like to see it. I can share.
I'd like to see it.
Yeah, let me just see if I can share this one. So this is a lady who was actually in her late 40s, and she was referred from vascular clinic because she had leg swelling and she looked a bit cyanotic, and she ended up in ED and was profoundly hypoxic and cyano. She was even clubbed, and this is what her TTE looked like. And you can see that. Can you see the screen?
Yep.
So this was her parasternal long axis, showing this huge right heart. And there was no real, good explanation for it. I think perhaps she hadn't even been worked up for this, but you could easily put this down to maybe some, OSA and pulmonary hypertension causing the right heart enlargement. But it didn't really make sense when we did this measurement, the relative atrial index, which is really quite simple and useful. And if you're getting a ratio of RA to LA area of more than 1, then you piques your suspicion potentially for an ASD. So I did a bubble study on her in ED, and it showed this. You've got bubbles moving from right to left, but it's difficult to say any more than that, like where it's coming from, whether it's intrapulmonary or intracardiac. Then we put some colour across the defect in the subcostal, just as Behny was describing. So that's the 2D.
It's huge.
And you're thinking already there, could that be a secundum ASD, or is it dropout? But in this view, as you were saying, with it being parallel, you would, especially in the setting of unexplained right heart enlargement, you'd be very worried about an ASD, and that's the colour flow there.
Yeah, that's nice.
Probably right to left, but with her circumstances, and she had significant pulmonary hypertension, there's concern about bidirectional shunt. So we went on to actually do a tour on this lady. This is quite phenomenal, these pictures. So it's what you were saying about the different views, Behny. So that's the short axis one where you can miss PFOs and what have you, but you can see, and just biplaning that, which I find biplane is useful for these, you can see that huge gaping defect there, which is a Secundum Asd. We tried to sort of get measurements and things of the rims. You can see it nicely here. She then went on to have a cardiac MRI and a right heart cath, because there was a lot of debate about, because she developed Eisenmenger physiology because of the the significant shunt over a prolonged period of time. So you don't just get that volume loading, but eventually you get pulmonary vascular remodeling and right to left shunt. She actually had bidirectional shunting. And if I can remember, Kadar is on the chat here, and he helped report her cardiac MRI. And they actually looked at her SVR to PVR ratios, which apparently, they use that to make sort of decisions about closures and things like that. This is just showing the Doppler, showing that bidirectional shunt, as well as looking at the rims and things like that. And I'm not, she was referred to the congenital clinic at St. Vincent's, and I'm not sure what's happened since then, but it's a really interesting case. And again, if after this one, it really sort of hit home how, an unexplained right heart dilatation, don't just always assume it's from pulmonary hypertension, from something like obstructive sleep apnea or whatever, which is, I think, what could have quite easily been done for this lady. But to go hunting, especially when you see that relative atrial index of more than 1, always go hunting for the ASDs.
Yeah, I think the pulmonary hypertension or significant pulmonary hypertension is a contraindication, right, to getting it closed?
Yeah, that's what there was a lot of discussion about. But there is, if and I'm not sure whether she did end up getting closed, but yes, it would be. But the question, I guess, is whether there's any reversibility, with the PVR. Like, is it fixed? Is it fixed raised pulmonary vascular resistance, or is there some reactivity there?
So I should say the significant pulmonary hypertension as a direct sequelae of the ASD itself. So if there's nothing confounding that, like they don't have like a pneumonia or acute respiratory failure or something else, obviously the pulmonary pressures are not reliable then. But yeah, I think because isn't it that if you close it and they have pulmonary hypertension, then that right heart can't offload anymore, right?
Yeah, I would think so. Then that's my understanding as well. So if it's irreversible pulmonary vascular remodeling and irreversible, significant pulmonary hypertension, then it essentially ends up being, I think, sort of medical management and essentially palliative sort of things.
If you would close it, you acutely worsen their right heart pressures.
Yeah. So that's all the discussion was for this lady, and obviously she ended up then. That's why she ended up having 2 right heart caths and a cardiac MRI to try to work out, what the PVR and SVR ratios and things were, and whether any of it was reversible. And then ultimately she was referred to a congenital clinic where they clearly see this more often and could make some decisions not only about closure but also about symptom management and I guess sort of palliative medical therapies if it was unsuitable for closure.
And it's the PVR SVR ratio, is that just to sort of work out what the hemodynamic effects of closing it would be?
I think so. Yeah. I mean, I don't know the ins and outs. I don't know whether Kadar's still on, whether he could offer any comment on that, because I think you and Faraz did the cardiac MRI for this lady, Kadar. All right, I might thank Behny and stop the recording there. Thanks so much. Excellent.
No worries. Thank you.
Thank you.
Thanks, Benny.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.